And then, Caitlin, we've talked about the induction therapy. We've said, okay, moving forward, if they are transplant eligible or ineligible, even before we get to that, how are you monitoring? Now, MRD is such a hot topic. How are you monitoring their response in your clinic after induction therapy?
So after induction therapy, we're probably just like you. Every month that they come in and they're getting their cycles, we're watching hopefully that M spike continue to fall down, those light chains continue to fall down. So let's say a patient decides to go to transplant as part of our usual typical myeloma work, or I should say transplant evaluation. It is typical to get a bone marrow biopsy both before the start of induction and following the end of induction to kind of get a sense of how much residual disease you have left. Now, MRD, very critical time point to talk about this right now, right? ODAC just met
Yes.
recently and recommended that MRD be a new endpoint for our clinical trials, where many of us have fought for that because I don't think either any of the three of us will be alive and certainly practicing by the time we get overall survival differences in randomized trials. But let's say that we can use MRD as a surrogate endpoint to make assumptions on how successful our treatments will be and to compare trials head to head to some degree. So, MRD, obtaining minimal residual disease negativity, getting to that point is just half of the battle. We think that getting there and maintaining it is likely going to be the most critical part of this. So, many trials now are doing MRD kind of risk, or I should say, adapted responses, where they will say, let's do a bone marrow biopsy and see if the patient has achieved MRD negativity. Continue on our treatment. Let's say that includes transplant and consolidation, maybe some maintenance, and think about some time point later, whether that's 6 months or 12 months, to repeat that MRD assessment to say, okay, we have what we've achieved. We've achieved what we wanted to. Two distinct MRD negative time points, a minimum of 12 months, let's say, apart. Maybe that's a time we can think about backing off a little bit. I don't know that that's ready for prime time now. That's what the clinical trials are looking at. I would even make an argument that I'm not sure MRD is truly ready for prime time for your clinical practice yet. What it tells us is probably more prognostic in value at this time point, but the hope and the expectation is that at some point it will guide our treatment decisions. I just don't think we're there quite yet.
Thanks for covering that because now the patients are reading all this information, especially after all this discussion at ODAC. Now, if a standard risk patient did achieve MRD negativity after completing the induction regimen, would you be inclined to back off the transplant at all or still consider transplant in an MRD negative standard risk patients and proceed with maintenance?
I'm giving
Okay,
the shrug because we don't know, right? We
right.
think that, as I mentioned, getting there is part of the battle, maintaining it is the other part of it. So,
Indeed.
you could make the argument to say, how much better could I get if I'm MRD negative prior to transplant? What do I need to go through that transplant process for if I've already achieved my goal? Don't know the answer to that. But I
Mhm.
think at that time point, it's not a wrong discussion to have with the patient to say, we're here. Our treatments so far have achieved the goal we want to. We likely could continue to maintain that goal and we'll need continued assessment to understand if that MRD negativity is durable. But we don't know. And that's what the trials are answering for us now. But it's not a wrong discussion to kind of review the risks and benefits for shared decision making with your patients at that time point.